Next, we will discuss preload and afterload. These are topics which you should be familiar with for step 1. Preload, which is another way of describing the stress the heart is under at the end of diastole, is approximately equal to left ventricular end diastolic volume or left ventricular end diastolic pressure. This is the pressure in the left ventricle before it starts to squeeze. Preload is increased with exercise because with exercise you see an increase in venous return. Preload is also increased with blood volume transfusions, as well as excitement, which is seen with sympathetic drive. In general, you should remember that preload increases as venous return increases. You can also see an increase in preload with venoconstriction, which is commonly seen with sympathetic overdrive. The mnemonic to remember is preload pumps up the heart. As preload increases, left ventricular end diastolic volume increases as well. Afterload is approximately equal to mean arterial pressure, or mean aortic pressure, and is also proportional to peripheral resistance. As blood pressure in the aorta goes up, so does the afterload. Remember that the heart is forced to pump against the pressure in the aorta. So as the aortic pressure increases, sometimes due to increases in peripheral resistance, afterload increases. The heart has a more difficult time pumping against a high afterload and therefore uses more oxygen to do so. Vasodilators, primarily nitroglycerin for example, decrease preload because they dilate veins, and as veins dilate, they can hold more blood, and because they can hold more blood, venous return decreases, and therefore preload decreases. Vasodilators, or arterial dilators, such as hydralazine and nitroprusside, will decrease afterload. This is because they decrease peripheral vascular resistance. Next, we will discuss the Starling curve. The Starling curve is a curve commonly seen on tests. You should remember that this curve is against the backdrop of an XY plot where the y-axis is equal to stroke volume or cardiac output. Remember that stroke volume is approximately proportional to cardiac output if the heart rate remains the same. And on the x-axis is preload, or left ventricular end diastolic volume. You can see that under normal circumstances, as the preload increases from left to right, so does cardiac output or stroke volume. This is the Frank-Starling mechanism. That is, the more the heart is given by the veins, the more the heart will pump out naturally. The heart has a desire to make cardiac output equal to preload or venous return. You can see the normal curve in the center of the diagram. Under normal circumstances, the cardiac output increases as the left ventricular end diastolic volume increases. During exercise, the curve is shifted up and to the left, which you can see. That is, for a certain left ventricular end diastolic volume, because of an increase in sympathetic nerve impulses during exercise, you will have an increased cardiac output compared to normal. With congestive heart failure, however, that normal curve is shifted downward and to the right. For a given left ventricular end diastolic volume, there is a decreased cardiac output. Drugs such as digitalis can help semi-normalize the CHF curve by shifting it up to the left, but you can see that it never quite approaches normal. The contractile state of the myocardium is positively affected by circulating catecholamines, digitalis, and sympathetic stimulation, and is negatively affected by pharmacologic depressants, such as benzodiazepines and alcohol, as well as loss of myocardium, which is commonly seen in myocardial infarctions or heart attacks. Next, we'll discuss the ejection fraction. The EF is equal to the stroke volume divided by the end diastolic volume. And remember that the stroke volume is equal to the end diastolic volume minus the end systolic volume. Ejection fraction is an index of ventricular contractility, and that is, the more contractile the left ventricle is, the higher the ejection fraction is. A normal ejection fraction is greater than or equal to 55%. That is, as the left ventricle fills, and after it's finished filling, you have your end diastolic volume. And then after systole, you will have your end systolic volume. Systole should be able to pump equal to or greater than 55% of the blood volume out of the left ventricle. If the ejection fraction is very high, we call that hyperdynamic. If the ejection fraction is low, we say that the heart has systolic dysfunction. Next, we will discuss some more formulas for resistance, pressure, and flow through the cardiovascular system. Flow through the cardiovascular system occurs because of a drop in pressure. The change in pressure from one part of the vascular system to another causes flow. Delta P is that change in blood pressure. That change in blood pressure is equal to flow, or Q, times the resistance. Q, or flow, is equal to cardiac output, and the resistance is equal to the systemic vascular resistance. This formula can be applied to the entire vascular system or to smaller parts of the cardiovascular system. This formula is analogous to Ohm's law, which is V equals IR. You can rearrange this formula so that resistance is equal to the driving pressure, which is delta P, divided by the flow, which is also known as cardiac output. Resistance is also equal to the Poisson equation, which is 8 times the Greek letter eta, which is the symbol for viscosity, times the length of the vasculature that you're talking about, divided by pi times r to the fourth. This is a very important concept to remember, because resistance in this case is directly proportional to viscosity. That is, as blood viscosity increases, the resistance to flow also increases. And resistance is also inversely proportional to the radius of the blood vessel to the fourth power. As the blood vessel radius drops, there is a very, very large increase in resistance, and that relationship is to the fourth power. So if the radius of the blood vessel drops by 1/2, the resistance increases 16-fold, or 2 to the fourth power. In order to calculate the total resistance of different blood vessels in series, you should simply add the different resistances, resistance 1 plus resistance 2, and so forth. However, to calculate the total resistance of blood vessels in parallel, you have to take the inverse of the sum. That is, 1 divided by the total resistance is equal to 1 divided by resistance 1 plus 1 divided by resistance 2, and so forth. We've already discussed viscosity. Remember that blood viscosity depends mostly on hematocrit. And remember that hematocrit is the percentage of the blood that is made up of red blood cells. As hematocrit increases, viscosity increases. And therefore, you see increases in blood viscosity in patients that have, for example, polycythemia vera, which is an increase in red blood cell content, as well as hyperproteinemic states such as multiple myeloma, as well as diseases such as hereditary spherocytosis. All of these diseases cause an increase in blood viscosity. And remember that as viscosity increases, so does the resistance to flow. And remember that an increased resistance to flow leads to a greater pressure gradient, and all of these can cause hypertension. Finally, it's important to remember that arterioles account for most of the total peripheral resistance, and these also regulate capillary flow. We call arterioles resistance vessels because as they constrict, the total peripheral resistance goes up. As arterioles constrict and dilate, they also control the blood flow through the capillaries distal to those arterioles.